Welcome to this explainer. Today, we are cracking open a literal medical time capsule from the year 1940. We're going to unpack a brilliant masterclass in surgical advocacy written by Dr. N. Sprott Heaney. We'll be exploring how a highly effective surgical technique became a lost art, exactly why it was forgotten, and how Dr. Heaney painstakingly fought for its urgent revival. It's a fascinating look into the evolution of medicine, the very real dangers of medical fads, and the meticulous, high-stakes nature of early 20th century surgery. To ground ourselves historically, you've got to understand that Dr. Heaney, a professor of obstetrics and gynecology in Chicago, wasn't just writing a boring how-to manual here. He was writing a manifesto. He saw a deeply concerning trend in his field, and he essentially used this paper to grab his colleagues by the lapels, pointing them back to a safer, far more effective surgical route that they were just completely neglecting.
And this quote right here perfectly sets up our historical mystery. Heaney writes, "Our grandfathers in gynecology were thoroughly familiar with its technique and indications." So you have to ask yourself, why was this well-known, highly effective surgical art suddenly entirely forgotten by the modern surgeons of his day? How does an entire medical discipline just lose a cornerstone procedure?
Well, here is our roadmap for today's explainer. We'll start with a neglected surgical art, then cover why choose this route, selecting the ideal patient, recognizing the danger signs, and finally, the surgical technique itself. Starting right off with Section 1, a neglected surgical art. Let's see exactly how a shiny new medical fad led to the total neglect of a superior vaginal technique.
So the root of this neglect actually lies in a sort of domino effect. When an older condition known as peritonitis was finally recognized for what it was, appendicitis, surgeons absolutely rushed to operate. They started constantly invading the abdomen, hoping to cure chronic appendicitis. And well, while they were in there, they got distracted. They started discovering what Heaney calls operative wrinkles, anatomic deviations like Jackson's membrane or a mobile cecum. Suddenly, they were placing a massive amount of emphasis on correcting these completely non-urgent issues.
Because of this intense, trendy focus on the abdomen, gynecologists got swept up in the hype. They basically abandoned their traditional vaginal surgical techniques just so they could combine their necessary pelvic work with these shiny new abdominal corrections. And the fallout from this was staggering. Dr. Heaney points out that vaginal surgery became so intensely neglected that you could walk into incredibly busy clinics and find entire staffs who had literally never performed a single vaginal hysterectomy.
Moving on to Section 2. Why choose this route? Here is where Dr. Heaney makes his comeback arguments to pull gynecologists away from the abdomen.
The crucial point he makes is that those popular prophylactic abdominal surgeries of the era were eventually exposed for what they were, meddlesome and frequently harmful. Dr. Heaney lays out the undeniable statistical realities. The vaginal route was simply statistically safer. We're talking less mortality, a smaller morbidity rate, and a much more rapid convalescence for the recovering patient. The data was crystal clear. It was high time for surgeons to relearn this abandoned art. In Section 3, selecting the ideal patient, Dr. Heaney puts on his professor hat, carefully laying out the strict ground rules for beginners operating in this highly restricted surgical field. And this brings up a genuinely surprising, counterintuitive fact about surgical anatomy. You might think a patient who's had multiple children, a multipara, would be the absolute easiest case for a beginner because there's a wider surgical field, right? Actually, no. Heaney explains that while you do need room for manipulations, a multipara might be too roomy. The vaginal walls can literally fall together laterally and completely block the surgeon's light and visibility. Because good lighting is indispensable, a nullipara, a woman who hasn't given birth, is often the safer, easier choice for a novice.
He also adds another golden rule. Beginners absolutely must select cases where the uterus is small enough to be delivered intact. Why does that matter? Because delivering it intact lets the novice surgeon promptly and clearly recognize the upper attachments, like the round ligaments. It's only later, once a surgeon has become a true expert at recognizing these attachments blindly, that they should ever attempt handling larger tumors by breaking the tissue into smaller pieces, a process known as morcellation.
Which brings us to Section 4, recognizing the danger signs. The tone here shifts dramatically to a serious warning about strict contraindications. Make no mistake, the stakes in restricted field surgery are incredibly high. If a patient has a history of previous pelvic surgery, especially a laparotomy, attempting a vaginal hysterectomy is wildly dangerous. Previous surgeries commonly cause the intestines to form adhesions, literally sticking to the uterine body.
If a surgeon goes in blindly through the vaginal route, they risk devastating intestinal injuries. Previous uterine fixations are also a massive red flag that you simply cannot ignore.
But hey, medicine is unpredictable. Dr. Heaney was a pragmatist. What happens if you take a careful history, everything looks completely fine, you start the operation, and then boom, you hit unexpected fixation or adhesions right in the middle of the procedure and you just aren't making headway?
In those moments, Heaney advises a strategy of careful boldness. Do not just blindly hack away in the dark. You stop the vaginal approach immediately, cut the cervix, suture any bleeding points, pack the pelvis tightly to press against the uterine body, carefully close the vaginal vault, and then safely finish the operation via a standard abdominal aportomy. It's a humbling detour for sure, but it saves lives. In fact, it's a detour Heaney notes he himself only had to make twice in his entire career.
Finally, Section 5, the surgical technique. Let's scrub in and step straight into that 1940 operating room to see the meticulous, step-by-step reality of this procedure.
The pacing of this operation is brisk and incredibly precise. It begins with putting the patient under using ethylene gas anesthesia. They are placed in a strict lithotomy position, ensuring the pelvis is angled perfectly. The area is swabbed with lugal solution. And then, fascinatingly, they do a direct injection of obstetrical pituitary extract into the tissue. This was a clever trick to make the operation as bloodless as possible before making that first anterior transverse incision.
Now, here's the gritty reality of the most critical part of the surgery. Separating the bladder from the uterus doesn't always go smoothly. It frequently requires sharp dissection. Heaney stresses that you have to keep the dissection angled towards the uterus to protect the bladder. But if an accidental bladder entry happens, it demands immediate attention. You have to stop everything and suture it instantly with No. 0 chromic catgut before you are allowed to proceed any further.
We're wrapping up this explainer with a pretty profound thought from John Homans, which Dr. Heaney featured directly in his text. It reminds us that, since the various genital organs have a very limited number of responses to disease, any one symptom may represent a considerable number of pathological states. It's a powerful reminder of the complexity of the human body, and it really leaves us to wonder, in a medical field where one single symptom can mask countless dangerous conditions, how many more vital, highly effective lost surgical arts are out there right now just waiting to be rediscovered?